All, welcome to Dental Notes and Mnemonics. Today we'll be discussing Class 3 Malocclusion. But before we begin, if you find my content valuable, please consider subscribing to the channel and hitting the bell icon so you don't miss the future videos. Sir Edward Engel, who is also called the father of modern orthodontics, in 1899 classified malocclusion into class 1, 2 and 3. He mainly looked at two things while classifying the malocclusion. The first is the position of first permanent molars and the alignment of these teeth along the line of the occlusion. When the mesiobuccal cusp of maxillary first permanent molar occludes posterior or behind the buccal groove of the mandibular first molar, then this relation is known as the class 3 malocclusion. The main limitations of Engel's classification were that it only looked at the anterior posterior position of the teeth, ignoring the vertical or the transverse problems. Second is, it does not consider the skeletal jaw relationship or the facial growth pattern. It was realized that just looking at the teeth was not enough. It was not helping in formulating a treatment plan. So the classification was modified to also include the jaw relationship. That means how the upper and the lower jaw relate to each other and growth pattern of the face. Now if we look at class 3 jaw relationship, it means the lower jaw or the mandible is more forward compared to upper jaw or even the cranial base. So coming to the prevalence of class 3 malocclusion, then it is the least common of all the malocclusion, constituting around 5 to 10% of the population. It is more prevalent in the Asian population when we compare it with the Caucasians. Class 3 malocclusion can be divided as the class 3 subdivision when class 3 molar relationship is present on one side and the other side is in class 1. Malocclusion can be classified into dental, skeletal and the functional based on the etiology. The dental type arises from tooth alignment issues with normal jaw growth. The skeletal type, also known as the true class 3, is due to abnormal mandibular or maxillary development, often presenting with A and B angle less than 0. The functional type or the pseudo class 3 results from forward positioning of the mandible due to occlusal interferences and typically shows a mild reverse overjet. Class 3 malocclusion is a multifactorial condition. It does not arise from disease but from the disturbances in the normal growth and development. The main causes can be grouped into genetic and environmental factors. Genetics play a very important role in the mandibular growth. Many studies show that higher the incidence of class 3 malocclusion occur in families. The classic example is Habsburg jaw, where the mandibular prognathism reoccurred in European royalty. However, the mode of inheritance is still debated. Some says it is autosomal recessive, others say that it is autosomal dominant, while some support a polygenic mode of inheritance also. Now, the environmental influences also contribute significantly. The wrong postural habits of the mandible, tongue thrusting and prolonged sucking can shift the mandible forward. Airway issues like nasal obstruction, nasal obstruction, mouth breathing and enlarged tonsils or adenoids further worsen the condition. Systemic and the local issues such as hormonal disturbances, trauma, premature tooth loss, cleft lip or the palate and the muscle dysfunction can also play a important role in the etiology of class 3 malocclusion. In short, class 3 malocclusion is a result of both hereditary and environmental influences. While genetics set the base, environmental factors can modify or worsen the severity. Malocclusion can be classified by jaw characteristics mainly into sagittal and vertical types. In the sagittal types, the maxilla and the mandible may show 6 patterns from the normal maxilla with a protruded mandible to the retrognathic maxilla with retrognathic mandible. Severe cases with protruded mandible or combined maxillary deficiency and mandibular excess often need surgical correction. while mild cases respond better to early growth modification. In vertical types, the mandibular plane angle is important. Average angle types have balanced proportions. High angle skeletal class 3 is difficult to treat with poor prognosis. And low angle functional class 3 is easier to manage if treated early. Transverse problems usually involve a narrow maxilla leading to posterior or scissor crossbites. To diagnose any malocclusion, we start with the detailed history, including chief complaint, dental and medical history, and family history. Then we start with the clinical examination, includes extraoral, intraoral, and functional assessment. Extraorally, facial profile, symmetry, and proportions are evaluated. Class 3 malocclusion, the lower jaw often appears prominent, giving a concave profile, while the upper jaw may seem underdeveloped. Facial asymmetry may be present, and balance between the upper, middle, and the lower third of the face can be altered. Observing these features help to determine whether the malocclusion is mainly skeletal, dental, or the combination. Oral examination assesses the molar and canine relationship, incisor position including overjet and overbite, and presence of anterior and posterior crossbite. It also evaluates crowding, spacing, rotated or tilted teeth, blocked out teeth, and any midline shifts. Assessment is also done. We will be discussing it shortly. Diagnostic records include photographs, study models, and radiographs. Cephalometric X-ray assess skeletal pattern, A and B, and mandibular plane angle. And OPG shows eruption, pathology, and symmetry. PA Ceph evaluates transverse discrepancies. When we suspect a class 3 case, we must check whether it is functional or skeletal. First, ask the patient to slowly close the mouth into the most relaxed and retruded position called centriculation. If in this position the incisors come edge to edge and crossbite disappears or reduces, it indicates a functional class 3 or pseudo class 3. But if the crossbite remains even when the mandible is guided back, then it is a true skeletal class 3. Another clue is A and B angle. In the functional cases, A and B values increases when the mandible is retruded, while in skeletal cases it stays negative. Let's understand dental compensation in class 3 malocclusion here. Dental compensation occurs when the teeth adjust their position to mask the underlying jaw discrepancies. As in class 3, the upper front teeth tilt forward and the lower front teeth tilt backward to improve the bite. This way we can correct the small overjet. But these compensations also have limits, and excessive compensation may lead to lip closure problems, gum issues, and relapse. Complete cephalometric evaluation includes skeletal parameters, dental, soft tissue, and profile parameters, and growth pattern assessment. Indicators A and B less than 0, width appraisal below -2 mm, and a prominent SNB suggests skeletal class 3. Width's value from 0 to -5 mm usually allows orthodontic camouflage using face mask or chin cup. Values from -4 to -12 mm require serial cephalogram and growth treatment response vector. We'll be discussing this in coming slides to decide whether the camouflage is sufficient or surgical correction is needed. Parameters like facial angle shows the mandibular prominence. The gonial angle reflects the mandibular growth pattern. The y-axis indicates horizontal or vertical growth, and lower anterior facial height shows the vertical proportions. These measurements help to predict whether the camouflage or surgical treatment is needed. Compensation can be seen as the upper incisor proclination and the lower incisor retroclination in cephalometric readings. Soft tissue clues include concave profile, prominent chin, and reduced nasolabial angle. Growth pattern also matters. Horizontal growers with mild discrepancies can often be treated with camouflage, while severe skeletal mismatch, vertical growth, poor soft tissue profile needs surgery. Apart from the regular cephalograms, serial cephalograms are taken multiple times during growth or after treatment tracking the changes in maxillary and mandibular growth. Dr. Peter Nan gave a growth treatment response vector or GTRV to measure the horizontal growth of jaws to predict class 3 treatment outcomes. Lateral cephalometric radiographs are taken after face mask therapy and during the follow-up. Using stable cranial landmarks, the horizontal growth of the maxilla and the mandible along the occlusal plane is measured. The GTRV ratio is calculated by dividing maxillary horizontal growth by mandibular horizontal growth. Ratios between 0.33 to 0.88 indicate a good response to orthodontic camouflage, while lower ratios suggest excessive mandibular growth and need for surgery in the near future. Let's discuss the management part of class 3. In case of pseudo class 3, it should be treated as soon as it is detected to avoid future dental and skeletal problems. Several appliances has been suggested in the literature for correcting a dental crossbite. These may be appliances may be fixed or removable. In mixed dentition, the 2x4 fixed appliance is commonly used. In adults, a full upper fixed appliance with an expanded upper arch is preferred. And removable appliances may use a Z helical spring or jack screw placed behind the upper incisor. There are three main treatment options for skeletal class 3: growth modification, depending upon the growth potential of the patient, dento-alveolar compensation or camouflage, and orthodontic surgery. Growth modification is an orthopedic approach aimed at correcting the skeletal discrepancies in growing patient. Treatment is sometimes controversial because not all the cases worsen with growth. But early treatment of class 3 malocclusion prevents dental and skeletal problems, guides jaw growth, minimizes dental compensation, and may reduce the need for the surgery. To Turpin, positive factors for early treatment include flexible malocclusion, favorable growth potential, mild skeletal discrepancy, and good patient compliance. And negative factors include severe discrepancy, vertical growth pattern, poor patient compliance, and high risk of relapse. Options for correction of class 3 malocclusion in growing patients consist of two principal categories: intraoral appliances and extraoral appliances. Is an extraoral appliance which is given for maxillary protraction when the upper jaw is retruded. They are often combined with a rapid maxillary expansion or alternate expansion or constriction or altermac to loosen sutures and enhance protraction. The forces are delivered by elastics usually directed downward and forward at about 30 degrees with a magnitude of 3 to 600 grams per side. The best time to start the protraction face mask treatment is between 8 to 10 years of age. At this age, the mid-palatal suture is broad and smooth, allowing effective forward displacement of the maxilla. Extraoral appliance which may be used is chin cup therapy, which is effective in restraining mandibular growth in growing class 3 patient, particularly in horizontal growers with mild to moderate mandibular excess. It can redirect growth backwards and upwards and improve occlusion temporarily. However, its long-term effectiveness is limited as mandibular growth is unpredictable and relapse is common if growth continues. Appliances act inside the mouth to correct dental and mild skeletal issues, mainly by repositioning teeth, guiding jaw posture, and modifying muscle function. Example includes reverse twin block, Frankel 3, class 3 elastics, and tandem appliance. Tandem concept in orthodontics means using the two appliances sequentially or simultaneously to achieve optimum skeletal correction in growing class 3 patient. It basically combines the extraoral and intraoral appliances to maximize orthopedic effects. Tandem appliance consists of three components. The first is upper appliance, which is fixed with bands on the second molars and transpalatal arch and palatal expansion arms, buccal arms for elastic retraction. The lower appliance has bands on deciduous second molars, a lingual holding arches there, a fixed bite plane for posterior occlusal coverage, and buccal face bow tubes are there. The outer bow of the headgear face bow has been modified to engage elastics, and it is inserted into the lower tubes. After phase 1 of the treatment, which includes the growth modification, phase 2 treatment is usually delayed until the second molar erupt to assess growth and reduce the treatment time. Males often show more forward mandibular growth in adolescence, increasing the risk of worsening class 3 malocclusion. After the growth is completed in the skeletal class 3 patient, we are left with two options: camouflage, which relies on dental compensations to mask the skeletal discrepancy, and the other is the surgical treatment, which is needed when the skeletal discrepancy is severe and dental compensations are insufficient. Camouflage treatment is suitable for mild to moderate class 3 cases with completed or near completed growth, minimal skeletal asymmetry, and good dental compensations. We need to extract the teeth, but extraction should be planned carefully to allow effective dental compensation. The lower first premolars are most commonly removed to create space for lower incisor retraction and correction of anterior crossbite. In some cases, upper first molar may also be extracted to adjust upper incisor inclination or managing the crowding. Occasionally, second premolars are removed for minor adjustment or specific anchorage needs. In the surgical management of skeletal class 3 in the non-growing patient, the maxilla may be advanced or mandible pushed back as the condition demands. Sometimes a combination of upper and lower jaw surgery is performed with reduction genioplasty. Class 3 malocclusion treatment choice depend on the severity. A and B less than -4 degree, lower incisor angle less than 83 degree suggest surgery. Predictive models using widths, SN, maxillary and mandibular ratios, and gonial angle helps to differentiate the cases. For borderline cases, Holdaway's angle guides the decision. Rabi et al. Suggests that Holdaway angles which is more than 12 degree for orthodontics and less than 12 degree for surgery, while Ben Haya et al. Propose 7.2 degree as the threshold. So this was all about the class 3 malocclusion and its management. Hope you liked the video. See you in the next video. Till then, bye bye, take care, and don't forget to subscribe to the channel. Thank you. Have a nice day.